Everyone. We're so excited to have you join our National Telehealth Resource Center webinar series. Thanks for joining today. With the excitement and stresses of graduation season, we're excited to share best practices in distance counseling in higher education. Just a brief reminder that the webinar series are part of a national telehealth series presented every third Thursday of the month. Just a few reminders about our federally funded telehealth resource centers. The resource centers are located throughout the country with 12 regional telehealth resource centers and 2 national centers, the Center for Connected Health Policy and National Telehealth Technology Assessment Resource Center. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. As we get rolling with our webinar today, just a few tips and house cleaning reminders. First of all, just remember to mute your phone, and your computer microphone has already been muted. There's time reserved at the end of the presentation for questions. Please type those into the question and answer component on the Zoom screen. We also really encourage you to please fill out the post-webinar survey. And just a reminder that the webinar is being recorded and will be posted through the National TRC. So I'm Evelyn Nelson, the PI of the Heartland Telehealth Resource Center. We're the resource center serving Kansas, Oklahoma, and Missouri. And it's my pleasure to introduce the speakers for today's webinar, which is Distance Counseling in Higher Education. Our first speaker will be Dr. Kathryn Alessandria. She's a professor of counseling education at Westchester University. She's a licensed professional counselor of mental health, a national certified counselor, and an approved clinical supervisor. She has experience in student affairs as a college counselor, academic advisor, and resident advisor. She is the current American College Counseling Association lead with HEMHA, which you'll hear more about in just a minute, and the lead writer for the distance counseling guidelines. And then after Dr. Alessandria shares her expertise, we'll have Dr. Larry Long share his experiences working at the University of Kansas Medical Center. Dr. Long has served as the Director of Counseling and Educational Support Services since 2001. He also provides leadership as KUMC's Assistant Vice Chancellor for Academic and Student Affairs. His team has utilized telehealth to extend counseling options to a range of trainees at the Academic Medical Center with a focus on extending access. He also leads broader health information technology initiatives associated with higher education. And then we're also pleased that Dr. Benjamin Visor Stanton is joining. He's currently a postdoctoral psychology fellow at the KUMC Counseling and Education Support Services Center and is a graduate of the joint JD PhD in Clinical Psychology program located at Golden State University School of Law and Palo Alto University. So please join me in welcoming our speakers and hearing their exciting updates about distance counseling in higher education.
Thank you, Evelyn. Good afternoon, everybody. My name is Tina Alessandria, and as Evelyn said, I represent the American College Counseling Association on the Higher Education Mental Health Alliance, which I'll explain in a moment. Our learning objectives for today are for you to gain awareness of what the Higher Education Mental Health Alliance is and how to access its free resources, to be able to define distance counseling, its many variations, and the circumstances under which it might be implemented with college students, to be able to identify logistical, legal, and ethical dilemmas in providing distance counseling in higher education settings, and to gain awareness of specific procedural workflow issues and challenges through the use of case examples of distance counseling with college students. The Higher Education Mental Health Alliance was envisioned and formed in September of 2008 under the leadership of the American College Health Association. The Higher Education Mental Health Alliance, which we also refer to as HEMHA, is a partnership of organizations dedicated to advancing college student mental health. The Alliance affirms that the issue of college student mental health is central to student success and therefore is the responsibility of higher education. And we do this through focusing on advocacy actions, policy development and review, practice dissemination, and the promotion of research across the mental health continuum. HEMHA is committed to advancing mental health throughout the realm of higher education and improving student recruitment, retention, and learning outcomes. We have 9 member organizations, and each organization can appoint up to 2 representatives. The current 9 organizations are the American Academy of Child and Adolescent Psychiatry, the American College Counseling Association, the American College Health Association, ACPA, College Student Educators International, the American Psychiatric Association, the American Psychological Association, and the Association for University and College Counseling Center Directors, the JED Foundation, and NASPA, Student Affairs Administrators in Higher Education. So you'll see there's a broad constituency of member organizations ranging from practitioners, mental health practitioners across a variety of disciplines, as well as administrators in higher education settings. And so we as a group are not a specific organization. So we move to each of our home organizations will host us annually, and our annual meeting is actually this coming weekend in San Francisco at the American Psychiatry Association conference. Next slide, please. The Higher Education Mental Health Alliance has several free resources. The one we'll be focusing on today is College Counseling from a Distance, Deciding Whether and When to Engage in Telemental Health Services. 2 other guides are also on the website. One is on Postvention, a guide for response to suicide on college campuses. Another is on Balancing Safety and Support on Campus, a guide for campus teams. And our 4th guide is currently in process on Emotional Support and Service Animals on campus. The way that our guides are created is that we will have a technical writer. In the case of the distance counseling guide, I served as the technical writer. And each home organization can appoint up to 2 advisory board members who are specialists in their discipline. So the technical writer will begin drafting something. Once we have a draft, we'll reach out to the advisory board, which are experts in that content area, to provide some feedback. And then once a final draft is created, with incorporating all of that feedback, it goes back to our home organizations for a final approval, final review and approval process. What was unique about the distance counseling guide was that it was a long process. It took about 4 years from the inception of the idea to the completion. And so there were about 4 different annual meetings where we were able to present what we were working on and get feedback from the audiences at different home organizations to inform what they wanted to see in the guide. And that ultimately led to several of the case studies that you'll see in the guide. Next slide, please. So the purpose of the guide is not to be a how-to document. With the case of telemental health, it is changing every day. The technology is changing every day. Best practices are changing every day. So the document instead was designed to guide institutions through the steps that they can use to make an intentional decision about whether offering telemental health services is right for the institution and for its various constituencies. To help institutions know what questions to ask in order to develop telemental health services that are congruent with the evolving best practices. And throughout the guide, there are structured activities and case studies to engage readers in thinking critically about the unique needs of their institution, the benefits and challenges of developing a telemental health program, and if the decision is ultimately made to offer services, then to think through how to effectively and ethically implement those services on campus and develop policies that would foster effective use of the tools. Because of the document's interdisciplinary nature, it can be a really great tool for advocacy, especially if the interest in adding these services might be coming from administrators, or if it's coming from somewhere else on campus. It can be used as a tool that says, hey, this is our common language to have conversations about how to develop a program in an intentional way and in a way that meets everybody's disciplinary standards for this practice that is continuing to evolve as technology grows. Next, we're going to get into briefly overview some of the benefits and limitations of telemental health. And you'll hear me use the phrase telemental health or distance counseling interchangeably throughout the presentation. So in order to engage in distance counseling services, we need to acknowledge that there are benefits and there are unique limitations of this mode of service delivery. And we need to carefully weigh those and then determine what policies and procedures we would need to put in place in order to maximize the benefits and minimize the limitations. So let's take a step back and actually talk about what is distance counseling. So it's anytime we're providing a therapeutic, a counseling service from a distance, but there's many different formats that it can take. Distance counseling could be synchronous, meaning that it's happening simultaneously between the provider and the recipient, or it could be asynchronous, meaning that it's not happening at the same time. So examples of synchronous types of services would be telephone counseling, video conference counseling, or a specific mode called telepsychiatry, which is when you might have a consulting psychiatrist at a distant location, but the client might be in the counseling center, in a room, meeting with that psychiatrist, and the counselor may or may not be in the room with that client during the consultation, but they're actually in the counseling center. Asynchronous, by contrast, is when it's usually text-based. So for example, services being provided over email, via text messages. And so each of these formats uses a different type of technology, and each type of technology can come with different security issues, as well as the ability to verify that the person on the other end of the line is who they say they are. So that is another important piece of the puzzle. So when we're developing these programs, to make sure that we are verifying the client's identity before we engage in providing confidential services. So talking a little bit about what some of the unique benefits of telemental health are. It can increase access by eliminating barriers for individuals. For example, individuals who might have disabilities or transportation issues. It can improve access for people who might be in remote areas, as well as limit disruptions to treatment during inclement weather, illness, or temporary breaks away from the campus. It can be more convenient for folks because of reducing travel time. It can make it easier to schedule, as well as cost savings. So for example, the client may not need to find childcare. They might not have to pay for the gas to get to the counseling center, or take time off of work, for if they're going for a 1-hour session and the travel time would make them have to take 2 or 3 hours off of work. It can be a great cost savings for the clients. It can also remove barriers, not just the ones I already stated, but there is some literature that suggests that individuals who have post-traumatic stress disorder, social anxiety, or agoraphobia can benefit from online services because they may feel less threatening than being in a face-to-face environment. Not having to go to the actual physical counseling center can reduce perceived stigma from actually being seen in the building. And then authenticity of emotional expression is an interesting one. There's a concept called online disinhibition effect. And this is the idea that people are maybe more likely to be authentic or share more intense emotions when they're not face to face. So think about things like when you're on your social media, do people say things that they might not have said if they were in person? And that's sort of that concept that there's a little bit of security from being behind a screen that might lead to people actually being more authentic more quickly. The effectiveness currently indicates that it is effective. Certainly the body of literature is still growing because the technology keeps changing and we're having a hard time keeping up. However, effectiveness is demonstrated in the literature, so that's another benefit. Client empowerment is that clients can feel a sense of control when they are in charge of their screen. If they feel like they need to leave a session, they have the ability to do that. The social justice aspect, by removing those barriers, we're creating a more equitable access to treatment for all students, including those from marginalized populations. And last but certainly not least is clinical capacity. So there are many variations of telemental health available, and they range from self-service psychoeducation, which are sometimes delivered through third-party platforms, to your traditional one-on-one counseling, which might be what you were envisioning. And so by using these tools, we might increase the number of students served, though that can be a double-edged sword if your office is already bursting at the seams in terms of meeting student demands. Next slide, thank you. So that brings us into some of the limitations. Confidentiality is an important concern in that when we're not in the same room with a door closed, we have to be mindful of all the ways that confidentiality could be breached and proactively mitigate those concerns. Some of that might mean having to instruct clients on how to maintain their own confidentiality, having conversations about where would be a good place for them to be when they're engaging in their sessions with you. So for example, not at the coffee shop. And also being mindful that there's no one in the room, no one else in the room who shouldn't be in the room at the time of the sessions. The interception of sensitive data in this day and age, we're all familiar with the large-scale data breaches, especially with credit cards. Similarly, we have to be prepared for preventing the interception of data and making sure that we're meeting current cybersecurity standards, which also continuously evolve. So the technology we use must meet current data encryption standards as well. And when we're using asynchronous technology, this could also add another layer. So for example, if you are providing a service through text messaging that's going to pop up on your home screen and you've stepped away from your phone and it's in a space others can see it, that's another concern. Keeping pace with ethical codes and best practices, because the technology is evolving and the ways in which we can provide services are evolving so quickly, codes of ethics from our professional associations and their best practices are not keeping track or keeping pace with those changes. So it's incumbent upon the practitioner to be really staying ahead of the curve with that and perhaps even participating in their home organization's review process of these kinds of codes. As I mentioned, while the literature out there suggests that telemental health is effective, the span of time that we've had for demonstrating that effectiveness is shorter than we've had for face-to-face. So the body of literature is a smaller body at the time. So we need more people to be doing research on providing these services so we can build that body of literature. Inability to see communication in context. We know that over 80% of communication is nonverbal. And so when we're using formats that don't allow us to see nonverbals, or even if we're using video conferencing and don't have a good camera angle or the room is too dark, there's still a lot of ways that we might be able to miss nonverbal cues, which can impact the service provider's ability to provide the best counseling possible. So we also want to make sure that we might have to instruct the client on how to create a good atmosphere to get the maximum effect and visibility to be able to provide the most effective service at times. Service disruption due to technical issues or maybe a power outage due to a storm. That if you have an abrupt service disruption, that's going to lead to some concerns both for the client as well as the clinician during that. So having a backup plan is a really important piece of the puzzle. Credentialing is also important. We're going to talk a little bit more about that later in terms of making sure that you are practicing legally by making sure that you are authorized to practice both in your location and that of the client. Administering assessments is something that can be a challenge online if the assessment hasn't been created for online administration, so that's something to look into. And making sure that if you're engaging in this, that your malpractice insurance does cover you. The lack of a technical infrastructure can be a challenge, so sometimes people will find themselves providing distance counseling because they're trying to be helpful to a student who's away temporarily and it hasn't been part of that thoughtful process. So it's really important to be planful and to make sure that you have the infrastructure, both hardware, software, and human resources on campus to be able to provide these services in a way that is effective. Crisis intervention plans need to be made in advance and before a crisis ever occurs. And finally, with HIPAA, clients cannot waive their right to HIPAA and choose to agree to use technology that doesn't comply with standards. So it's on the practitioner to ensure that any site used to log on or store client data meets encryption and security standards. So informed consent, and I want to acknowledge that Dr. Long actually provided the sample informed consent that's in the distance counseling guide. He was on our advisory board for the project. And he and Dr. Bazar-Stanton will be discussing this a little bit more in their section. But it is important to have a careful informed consent and talk to the client about what's different about informed consent, because one of the best practices recommends that there be a collaborator in the location of the student in the event that there is an emergency, and making sure that that backup plan is in place well before any emergency occurs. I briefly mentioned the staging of the office environment earlier when I talked about things like lighting. We've all had that picture where the sun was setting behind us and our face ended up in shadow. So there's a little aspect of learning about setting the stage, so to speak, and for counselors as well as clients to have to learn about sound quality and lighting and how to make the most ideal environment, as well as learning about gaze angles and where to look to simulate eye contact when you're communicating with somebody through a screen. And certainly, we all know technology is changing fast, and so how do we keep up with those changes and advances and keep our technology up to date, whether it's a security patch or keeping up with any sort of changes in terms of best practices. One of the aspects that's really important is to consider, why do we want to engage in distance counseling on our campus? And so some of the things that we need to consider are, does our institution have an accreditation requirement that's saying that we really need to find a way to serve our students who are being educated from a distance? Regional and program accrediting bodies usually require student access to support services, including counseling. And so if we have a gap in who's being served by our counseling centers, that might be part of the impetus for wanting to add these services. Asking, does our institution have the technology infrastructure in place to offer the services as well as the support for upkeep in providing the needed services for students who might be at a distance, as well as thinking about if counseling centers are currently functioning at capacity. If we're choosing to add this service modality, how will that increased demand for services be addressed? Will we need to hire additional staff for the counseling center? And what will be the parameters for the counselors in terms of, will they be asked to work from home and after hours? Or is this something that we're adding as an option during normal business hours? So these are important aspects to consider so that institutions can plan for additional resources that might be needed in order to effectively roll out these services. Because if you add distance counseling and it just exacerbates your wait list, then that's not helping what the problem that you were hoping to alleviate. So on this slide, I'm not going to get into the weeds too much here, but this is an example about the type of stop and think activity that you might find in the distance counseling guide. And before we offer these services, it's important to determine who would be eligible for services and who might not be eligible for services. And that might range from considering things like which students pay for the fees that fund the counseling center on campus, what type of student would best be served by distance counseling, or is there a type of student issue that would better be served by face-to-face, especially if somebody's a more high need client. And so it's really an important element of thinking through these things and thinking about what kind of policies we might put in place about eligibility for these students. If the student who's in the dormitory that's 5 minutes from the counseling center doesn't want to come for a particular day, would that student be eligible, or does there have to be a demonstrated need? And so that's something that institutions have to plan for and decide ahead of time. There are several logistical dilemmas or concerns that we would have to think through prior to engaging in distance counseling. And so again, this is another segment where Dr. Long and Dr. Bazar-Stanton will be elaborating through their case study. But it's important to think about things like, how will we make sure that we're using HIPAA compliant technology? And that's not just for how we communicate, but also any data that's collected. Which data would be saved, and are these services meeting not just HIPAA but also FERPA regulations? And this is particularly important if you're also serving as a training site and you might be recording counseling sessions for supervision at a later time. And so making sure that the clients are also fully informed of all of this. Also, if we have technical glitches in the midst of a session, who will be providing that technical support, both for clients and for staff? So that's important to plan for ahead of time, and what additional training might anyone who's providing that technical support need in terms of understanding the sensitivity of the data that they're interacting with in that process. Again, data security is of the utmost importance. So getting into, there's a lot of overlap between logistics and ethical and legal issues. So privacy and confidentiality are fairly straightforward, but the training competence considerations are something we need to talk a little bit more about, because many of the ethical codes are starting to add qualifications regarding professional competence in delivering distance counseling services. However, it's such a new mode of service delivery that there aren't a lot of people out there who have that expertise to be able to be developing that training. Towards the end of the slides, there are some resources out there for places that do provide some of that training, but those training standards are also continuing to change. So if your institution is deciding that they want to engage in these types of services, is there going to be additional training that's required for the counseling center staff? Not just in how to use the actual technology, but is there continuing education requirements as well in order to maintain credentials, or credentials that are required in order to become a distance counselor based on their professional standards? So last but not least, for my section, and again, Dr. Long and Dr. Bazar-Stanton will be getting illustrating this through their case study. We need to be mindful that if we're practicing across state lines or international boundaries, that we need to find out what are the regulations so that we're not breaking any laws by practicing across state lines. You need to check both the licensure law both in your location and the student's location before providing those services, and verify that your malpractice insurance covers the provision of telemental health services. It's really important to be proactive on these elements.
Okay, this is Dr. Larry Long. First, let me just say I really appreciate Dr. Alessandria's work on the guidebook. I think the Higher Education Mental Health Association has done a phenomenal job providing really useful resources for university and college counseling center settings. One thing, though, that's really interesting over the last 2 years in particular, we've seen this proliferation of changes with state laws concerning guest practice and telehealth requirements within the state. I'll talk more about our site and sort of how we've navigated that, but every time I look at the different compacts that are provided by the different healthcare professions, it seems like another state is added. About 3 months ago, 7 more states were added to the medical licensure compact. In the nursing compact, I think it held steady in the last 3 months, but they have quite a few. The psychologist, the Psych Pact, just added another several. Last I heard they were up to 10, which gave them the threshold necessary to execute their e-passport, so that this will allow for interjurisdictional practice in a more fluid way. Part of what's been accelerating the progress is that a lot of states are now requiring health insurance companies to include telehealth as a part of the what they will reimburse. So say I'm a Massachusetts psychologist treating a student who's on spring break in New Hampshire. Last I checked with the telehealth regs for the New Hampshire guest practice laws, an out-of-state psychologist may temporarily practice within New Hampshire for under 30 or 30 consecutive or non-consecutive days per year. As long as their license meets the criteria, the Massachusetts license meets similar requirements that the New Hampshire license requires, and the out-of-state provider holds one of the Association of State and Provincial Psychology Boards, CPQ, IPC, or the provider has the ABIP, or is a part of the National Register's HSP certification, or has other equivalent qualifications determined by the board. Now that's for guest practice, but the question you should think, in addition, if you're a Massachusetts provider wanting to treat a student in New Hampshire, is does Tarasoff apply? So we live 2 blocks, or my office is 2 blocks from the state line, and I'm in Kansas. Missouri is 2 blocks away. Missouri is a Tarasoff state, Kansas is not. I think those are some considerations that one would wish to have when you're thinking about interjurisdictional service. At the University of Kansas Medical Center, we are a health science campus about 40 miles away from our main campus, and our department services 3,000 health science students and residents. So this is medical students, nursing, OT, PT, RT, all the PhD bioscience students. Our clinic provides about 700, a little over 700, or services to a little over 700 clients annually. So we see a little more than a quarter of the population, or somewhere around there. We have 3 campuses. Our main campus is in Kansas City, but we have students who are in Wichita and Salina. We have contracts with local mental health providers or groups in those cities for short-term counseling, but our clinicians go to those campus sites about once a month or so and do telehealth screenings with students. We primarily provide individual counseling sessions via video, and sometimes we'll do couples. We implemented the program in 2012 and have had more than 1,000 video counseling sessions since 2012. All of our providers or our postdocs complete training programs and a certification in one of the training programs. We've tried varying ones over the years. Here are some examples of some, and if you download the slides later, you can see the links to those different programs. I have no stake in advocating for one over the other. I think you'll have to see what best fits your budget and your site's needs. I can't say that my experience in having gone through all of those different programs that any is better or worse. But we require that anyone who's going to provide telecounseling services complete one of those training programs, review the Higher Education Mental Health Association guidebook, and then we do some simulated practice with those providers. We're often talking about and working on our office setup for lighting and background and eye gaze and engagement and any of the other sort of nuances that's unique to telecounseling services. Of course, it's important to have those conversations with students as well. We use a platform, we use Zoom Healthcare, which is different than the traditional Zoom Pro that some folks might have, or this is what this webinar is being provided on. There is a cost for that per provider that we use, but it's a HIPAA-compliant BAA technology using HD cameras that we get from Logitech. Our EHR software has an online client portal where we provide online scheduling, secure messaging that's not email, that's captured in the client's chart. We do our consents, visit questionnaires, and our surveys all remotely. So this would be an example of what a client might see when they come for their telehealth appointment. We don't necessarily have to send them a Zoom link. They can go to our portal, complete the surveys, complete the questionnaires, and click Join Meeting, and Zoom will start. During our on-site, face-to-face initial telehealth screening visit, we have our students complete one of our informed consent forms. If they're going to be recorded by a postdoc for their telehealth encounter, they would sign another authorization for recording as well.
Hello, everyone. This is Dr. Ben Bizarre-Stanton, and I'll be talking to you about a use case based on a client that we've worked with, and we've named her Isabella. She's a 19-year-old Latinx, cisgender, heterosexual senior nursing student. Has a history of generalized anxiety and panic disorders dating back multiple years. The presenting issue that brought her in for our services was experience of a panic attack after receiving feedback from one of her supervisors. And the reason for telecounseling, the reason it was indicated, was because she has preceptorships in both Kansas and Missouri, and that would prevent her from regular in-person attendance. So just thinking about the initial encounter, the way that we do it at KU Med Center is that every initial telehealth intake is in-person, on-site, face-to-face. And we'll go out to our Salina campus or our Wichita campus, and we will have these face-to-face on-site visits. And for Isabella's initial encounter, I'll briefly be reviewing with you the consent and orientation to telehealth that we went through with her, in particular starting out with the screening criteria that we use. So we adopted our screening criteria from the Department of Defense's criteria that they had set up for telehealth, and then we adapted it to meet our needs and our specific population's needs. And so we will go through a checklist and look for recent suicide attempts, psychiatric hospitalization, or psychotic processing within the last 3 years, moderate to severe major depression or bipolar disorder symptoms, moderate to severe alcohol or drug abuse, severe eating disorders, and repeated acute crises. And Isabella did not meet any exclusion criteria. And just a clinical consideration with her is presenting with lots of anxiety. And so on the front end, just explaining to her the rationale and the process for this initial telehealth screening criteria.
Ben discussed the benefits and limits of telehealth with Isabella. We always reserve the right to modify the service format if we have a perception that we're underserving the client. And I hope you'll take that to heart. It's really important if you go down the road of providing telehealth that you consider this is an ongoing assessment, an ongoing decision about do you continue in the medium and in the approach. But Isabella wouldn't have been able to attend counseling on a regular basis and get support and get the treatment that would really help her unless we provided telehealth. Also, she was quite apprehensive about coming to counseling and being seen by her peers as having problems, and this allowed us to be able to have the kind of engagement that would allow her to be more authentic and free to come. With that, I think there's also, if you're advocating on your campus for a lower stigma, one of the challenges is for Isabella, it may have helped more had she been able to come into the clinic, had encounters, and had the exposure experience of walking through the door and engaging with staff. And we find a lot of our on-site clients benefit from that. But as Dr. Alessandria had indicated, you lose a lot of nonverbals, and there's some limitations in terms of the quality and the type of experience when you're not on face-to-face.
And so one really important consideration in the initial encounter, and Dr. Alessandria had talked about this earlier, is privacy, confidentiality, and legal issues. And so in particular for Isabella, she presents a unique challenge because, as Dr. Long mentioned earlier, KU Med Center sits right on the state line between Kansas and Missouri. Luckily enough, the person that was supervising me on this case is licensed in both Kansas and Missouri. But if not, there are quite a few different things to consider regarding different state jurisdictional laws and requirements. Our in-home Kansas requirements versus our out-of-state Missouri requirements. And I'll actually show you a couple of links that take you to statutory differences on the next slide. But in particular, you first start out looking at guest practice laws in Missouri if you weren't licensed there. And then, as Dr. Long mentioned earlier, thinking about differential limits of confidentiality. So in particular, terrace-off duty to warn considerations differing in Kansas versus in Missouri, with Missouri being mandated duty to warn. And then another consideration with telehealth, and in particular Isabella, was her change in location from session to session. At times she'd be at her parents' house, at times she'd be at her house with her fiance. And part of the issues that she was struggling with anxiety involved both her parents and her fiance. And so thinking about informed consent whenever she changed her particular location, regarding how to maintain privacy, how to make sure that her location was not necessarily impeding her ability to speak freely and engage authentically and meaningfully. And that's a conversation that we would have across sessions. And so here is a statutory list compiled by the American Psychological Association that has comprehensive or some summarial information about telehealth statutes and regulations that you'd be able to look through for all 50 states. And in particular, talks about temporary guest practice provisions. And our policy is going through, checking to see if there's a guest practice provision, and then going to the actual provision. And then thinking about duty to warn differences. On this website, they list the different requirements for a terrace-off duty to warn between mandatory, permissive, no duty to warn or protect. And so this is a good place to start, but it is by no means the extent of which you should look into the different statutes and requirements for each state. And then again, crisis and emergency planning is important to think about ahead of time. And again, consulting specific jurisdictional differences and requirements and laws, and then thinking about a safety plan. And so the standard components of a safety plan, talking about early warning signs, maybe of some increased suicidal ideation, internal coping strategies, support contacts, emergency numbers and hotlines, making the environment safe if necessary. And then thinking about different plans based on location differences. Is Isabella at home versus is she at a clinic or another location with other mental health professionals? And then thinking about involving a collaborator ahead of time, preemptively getting a release of information so that you can contact this collaborator, somebody who's close to Isabella, if need arises. Doing a review of local emergency help. How do emergency responders do responding to wellness checks, et cetera, things like that. And then having a secondary mode of communication if for some reason the technology fails and you need to make a phone call.
As a common practice for us, we will go from Zoom, from a video format, to telephone if within a couple of minutes there's some glitch with the video, there's some glitch with the audio. But as a general practice and a recommendation I would have for you starting and working in the telehealth medium, don't spend a lot of time with technology problems. Go to a landline, go to a cell phone. One of the things that's really been amazing over the last 7 years, as you know, is the technologies have advanced so much that 5 years ago, I wasn't typically having televideo or telecounseling sessions on someone's cell phone, but that's probably more the norm than the exception these days. Oftentimes it's a tablet, sometimes it's a laptop, often it's Wi-Fi, often it's cell connection, but Zoom healthcare has worked very well. But in addition, we talk to folks about interruptions, like what's the plan should somebody knock on the door if the UPS FedEx person comes, or should someone come in unexpected, what's going to be our game plan, and or what if someone is upset and somehow the conversation gets interrupted, how will we do it, and and so then those things do occur, and there are opportunities to have reparative discussions should it be upsetting to the client. But I think it's wise, especially when you do the consent, that you talk through those options and those settings.
And then thinking again about Isabella, and just a clinical practice consideration that I came across was thinking about interoceptive exposure for her specific panic symptoms. And there's some research out there showing efficacy of interoceptive exposure via telemental health. But for me, thinking about in-person versus telemental health considerations, I feel much more comfortable if the person's in front of me, if they start to experience more significant feelings of panic. And so with Isabella, we really did a lot of planning ahead for what would happen if she did start experiencing more intense symptoms of panic. How does she implement these coping strategies? Is there a collaborator on site? What happens if technology fails and panic starts? Thinking about having that secondary mode of communication. And these are just some of the things that I thought about and addressed with Isabella, but it's important to try and consider these things ahead of time on the front end of treatment.
So this is our final slide. If we were to end our telecounseling program tomorrow, a number of our students and residents would not receive services, in part because we have remote campuses, and while we do have contracts with regional providers, those contracts are limited, and also the providers at our clinic are fairly specialized in knowing the day in the life of a health science student or a healthcare student or medical resident, meaning the kind of context they're in and the kinds of challenges that they face. Our students in general maybe are not often as much financially poor, but they're definitely time poor. And so while someone's in 90 minutes away or half an hour away, being able to come to our campus and come within the hours of our services can be really challenging, but being able to find a way to get to a private location to be able to have a telecounseling visit is often much more tenable. And a lot of times the academic and clerkship responsibility really prohibits travel time, sometimes prohibits being able to seek out help. We've also found that being able to get people who necessarily wouldn't be willing to come see us, we've had more engagement with services. We have two kinds of folks that get telecounseling, the folks that would get it from the onset and folks that would get it as an extension of their current treatment, or should they transition to more of a clerkship responsibility. And the continuity of services when we weren't providing telehealth were significantly disrupted or limited for those students who had started with us when we weren't providing telehealth. So we will end our formal presentation there and look forward to hearing your questions.
Super. Thank you both all for your fantastic presentation and also for such a thoughtful approach to meet student needs. We had one question about whether the PowerPoint would be shared, and that will be shared through the National Consortium website along with the video recording of the presentation. I'm going to start with a couple of questions that have come in. I encourage you all, if the audience has other questions, please do enter those in the Q&A section. Our first question is, could you talk about special issues that might relate to study abroad or international students?
Perhaps Dr. Alessandria could talk about her experience. We've taken the position where we do not provide services to students who are overseas or studying abroad, and in part it's because we recently, I suppose up until 2 years ago, we were, since our providers are licensed in both Kansas and Missouri, we were only providing services through telehealth or telecounseling in Kansas and Missouri. Because the guest practice laws have evolved so progressively, we've opened that up over the last 2 years, but because we're not aware of what that international or that country's statutes are related to the provision of mental health, we've taken a position to not provide services in that context.
Thank you, Larry. I cannot say yes, no, you should, shouldn't. There are a couple of case studies in the distance counseling guide that might help you to think through whether you should or should not. So there were examples in there of, like, when I think it was in Paris when there was a terrorism issue and there were a lot of students who were studying abroad, that an institution decided ultimately that the benefit outweighed the risk, but you would probably want to consult your legal counsel before providing services abroad. And also, are you providing those services to students who speak the same language as you? Because there are also cultural competence considerations if you are providing services to someone in another culture that you're not familiar with. So that's what I would add to what Dr. Long suggested.
Thank you. Those are all excellent points. Our next question is, if the student's from Ohio and you're a mental health counselor at University of Southern Mississippi, could you see that student via telehealth? Wouldn't they technically be considered an Ohio resident? Same for co-ops and internships. The question is really about residency and what establishes the residency piece.
That's a wonderful question. I think one of the more misunderstood challenges in providing telecounseling. If you think about it, of course, it makes sense to me that the provider is going to be licensed in the location where they're sitting or would have the appropriate credentials to be able to provide the service. Licensure boards, though, are available to protect the public from problems that a provider might do or give. And so it's probably really important to think that wherever the client sits is where treatment is happening. At least that's the stance that we take. and that state's jurisdiction or laws or rules would all apply and would need to be considered. So then the question is, what are the best practice laws for Ohio, and how would they impact if you were licensed in Mississippi? And then also you'd want to look at the privacy laws that Dr. Bazar-Stanton had mentioned to make that kind of decision. But I think it's really important that you consider, if your client is sitting in Ohio, that that's the location for which they are receiving services.
Great. Thank you for that overview. I'll just add in that our telehealth resource centers would be another group you may want to reach out if you have those kinds of state-specific questions. Our next question is, do you know if any grants are available to assist universities with starting up or maintaining telemental health programs?
I am not aware of any specific grants, but I can say that there is a link to the SAMHSA website in the later resource slides. I have not taken a deep dive in there to see if there's anything. Do you know of anything, Dr. Long?
I was hired last year by the University of Missouri, Kansas City to provide tele-counseling, telehealth ethics and training seminar, a day-long program, and it was a SAMHSA grant. So I'm not aware of specific programs, but I talk with folks who know that we do this in our region will reach out to us when they're considering different grant applications, but I'm not aware of one that's specific on telemental health.
Great. Our experience has been with SAMHSA as well, and funding one of the rural college telemental health programs. HRSA might be another option to consider. Our next question is, has your institution had to purchase additional insurance for telemental health?
No. They have not, but we, all of our providers have malpractice coverage, and I'm not advocating that people who are psychologists get the trust, but I have insurance through the trust, and should I have any questions, I found that the trust attorneys are very accessible, and I will call them and ask them about interjurisdictional practice questions or concerns I might have, and they usually have a quick response and a thoughtful response about managing risk and being thoughtful with your practice. But our institution has not purchased additional insurance.
Great, thank you for that guidance. A second question is, what platforms besides Zoom healthcare may be available?
There are actually quite a few. I think if you go to the telehealth.org website, you can, I believe it's telehealth.org/video, and you can find a host of telecounseling, BAA, HIPAA compliant products that they would share. A common one I hear is VC. I would imagine maybe others who, Dr. Alessandria or Evie Lynn, maybe you know additional resources?
I'm not well versed in this specific technology. In the guide, we tried to stay away from making recommendations about specific technology so that the guide would have a longer shelf life. I do know that Skype is still not HIPAA compliant, or I believe that it's still not HIPAA compliant. So it is something that any technology you use, you need to do the research to make sure that it is meeting all the requirements.
That's really a good point. Again, I would encourage talking with the Telehealth Resource Center, and then also that there's a Telebehavioral Health Center of Excellence that more asks, it gives kind of the kinds of questions just like you articulated, that you would want to think through when working with a vendor. Our next question is, are all your clinicians credentialed in telehealth, or do you have a designated telehealth group of clinicians?
Our clinic is relatively small. We have 4 psychologists and 2 postdocs, all of which are required to complete a telehealth certification program every other year, or at least for our postdocs, the initial time that they complete it. We don't have a designated group of clinicians, although I hear at some other sites around the country, they have subgroups that tend to be the telehealth go-to folks. I guess the question really would be more for if you work at a clinic where for its entirety or for most of the treatment course, the plan is to provide telehealth to the individual. Where it's been more of our experience is while we get some of those, it's often an extension to what we might do on site with people. So it may be that we work with people for a while on site when the circumstances are favorable for that, and then switch into a telecounseling medium when it is not. And I would imagine then that would make you want to think about I guess the question is, who would you restrict or who would you not have do telehealth? Let me just throw this in as well, because I think Dr. Alessandria had said this earlier. If your clinicians are already doing telephone sessions with people, they're already doing telehealth and telecounseling, whether or not you have guidelines or policies or procedures on that. And I think it's really important to consider that, because that's been a common practice at a lot of places. And I think I worry about crises and other challenges that aren't always thought of, and interjurisdictional practice and whatnot, especially if it's not in the instance of a crisis.
Yeah, that's an excellent point. I know we're at the top of the hour, so I know folks may need to sign off. We have 3 questions remaining, so if the speakers continue to have a chance, we might go ahead and ask those questions. But again, I know many folks may need to sign off, and I do want to make sure we've thanked our speakers for all this wealth of information. A next question is about how do you have folks sign consent when they're at a distance?
We have, most of the time, when we do a telehealth screening, it's essentially our intake process plus the telehealth screening, and then orienting the client to telehealth services. We typically do the consent at that time. Say though it's an ongoing client, somebody that you've seen for a period of time, it's your assessment that they've met the criteria and you're very familiar with them. We have a way to deliver the telehealth consent through our EHR, through our patient portal, where they can complete it online, and it goes into our EHR directly.
Great. It's sure an important question, and it's good to hear that other technologies may assist with that component. Another question that we've received is related to students who only take online courses and may pay different fees than students who take face-to-face courses on campus. Does this affect the ability to serve them over telemental health?
I think that's a great question. I think that's the kind of thing where you need to sit down and walk through some of the steps in the guide to help you think through who's paying for the counseling services on campus. Do students who are who are being served at a distance pay a separate technology fee. And so how is that fee structure going to work? And that's the kind of place where we might bring other stakeholders like administrators, budget and finance into the mix to say, if we're going to add this type of service, how will we pay for it? And does that affect student eligibility? So I think it's the kind of thing, at least in my experience, where the institution itself would have to make a decision, and that comes back to being planful about your policies about who is eligible. Another example we have in the guide is a student who is taking an online course over the summer. They're not a matriculated student, but the professor sees something concerning in their assignments. Would they be eligible for services if they're not a matriculated student? So those are the kinds of things you need to step through and think about. When is somebody our student, and when do we need to provide those services or a referral to someplace else?
Thank you. That really helps in thinking through some of the details. A next question is are the services billed? We find that telemental health pays well among commercial payers. How do you find payment at your institutions?
I don't have much experience in that. We don't bill the students for our services. They pay a fee, and then we receive funding from the state for our services. I know that if I wished to add on a fee component, either a copay or a fee for session component, our EHR has an integrated component for that we could pay for and pay up. I imagine that a number of sites might have different ways that their health center could collect fees remotely through some online bill pay kind of thing. Or, and then there's always the issue. I know we do charge some. We don't provide telepsychiatry. We do have a psychiatrist on site, but that service is under-resourced, so we only provide psychiatry services on site face-to-face. And we do charge fees for that person. And the question comes up is, do you put that fee on the student's bill? Because we could do BUSAR billing and add it to the student's bill, and then how do you label that fee, and how does it go through, and do their parents see it, and those kinds of things. All of those things are really important things to consider, but I don't have much experience or much to say about the commercial payers or sort of the process of collecting insurance and copay and so forth.
Dr. Alessandria, is there any other thing that you would add to that?
I don't have anything to add. I can't say that I have experience with that. I think another thing to consider, though, is your institution providing your distance counseling services in-house, or is it contracted out to a third-party provider? Because there are third-party providers out there that do that. So I think exploring the costs of outsourcing versus what it would cost to develop your own in-house program and the technology infrastructure and all of that would be important to consider. But I think a lot of institutions vary in how they charge or don't charge, and I've never been at an institution that has funded their counseling services through student paying per service as opposed to it being funded through student fees. So I can't add to that, I'm sorry.
No, your point is really good, though, just around planning and doing business planning and thinking about pros and cons with in-house and outsourcing. And then our final question is thoughts about using telehealth for continuity of access to the service provider. For example, if a provider is working with a student who goes to a conference elsewhere or out of state or even out of country.
I would say that sometimes we also need to stop and think about kind of the boundaries for ourselves. If you are not in your normal location, how are you going to maintain, are you on a secure wireless network where you are, or is it an open access network? And do you end up offering something that once you find that you've gotten there, you can't promise that level of security that you once did. But also, you know, I know for me, when I go to a conference and I'm a place that I'm trying to be focusing on my own growth, sometimes we need those breaks. And so I think some of that's also about self-care and boundaries. As for being out of the country, another just logistical issue is time zones. For example, let's say somebody is in China from where I am, that's 12 hours time difference. It might be really hard to find a time in your day where you're at work and they're not asleep to actually schedule that. So I think from a logistical perspective, being planful to decide whether you'll engage in that, because once you offer it to one person, are you obligated to offer it to all people? And so that's what I would say. Do you have anything to add, Dr. Long or Dr.
No,
Bazarski?
I think you've stated it quite well, and I would imagine, Dr. Alessandria, at your conference this weekend, you'll notice that people leave their conference sessions to go in the hallway to have a telephone call consult with another provider because of a patient crisis or something. And it seems like it's something that we contend with, be it a formal like counseling session when you're off-site, out of state, or a crisis call, or those kinds of things. But it just makes sense what you're saying in terms of the thoughtfulness and the planning and the boundary and the organizational expectations. And also sort of the, you know, if you absorb that as a clinician, your site, your organization doesn't necessarily have to step up and figure out how to address that problem if that's a need within the center. And it makes sense to me that those boundaries really help accelerate, if that is a problem, administrators to be able to either fund or figure out limits of service or something necessary to be upfront with the students about what we can and can't do.
Yes, absolutely. And we don't want to burn ourselves out, which I think is what you're ultimately also getting at. So how do we make sure that we take care of ourselves so that we can take the best care of our clients?
Yep.
I think that's a wonderful place to end, and so well put. I just want to thank you all again as our speakers and our audience. A really fantastic presentation. I hope you'll join our next National TRC webinar, which will be Thursday, June 20th.
Thank you.
Thank you.